Good morning, dear students. Now, I'd like to teach you two important pulmonary diseases. One, bronchial asthma. The second one is COPD, chronic obstructive pulmonary disease. We'll first start with bronchial asthma. So what's asthma? What does it mean? Asthma is a complex disease, a chronic inflammatory disorder of the airways with the presenting symptoms. Patient presenting with the following symptoms. These are wheeze, chest tightness, cough, and shortness of breath. Asthma have three classical characteristics. One is airflow limitation, that is the airflow when the patient inhales or exhales, there will be bronchial obstruction. Bronchial limitation, airflow limitation will be present. Then airway hyperresponsiveness. This is the classical feature of asthma which differentiates asthma from COPD. The airway hyperresponsiveness, the airway closes prematurely whenever they are exposed to any allergen, they immediately collapse, and this is the classical feature of bronchial asthma. There will be constant chronic bronchial inflammation. If we look into this picture, there is a big mountain which is obstructing the mighty ship Titanic, and this mountain is constituted by symptoms. The symptom before they emerge. Underneath the sea, there is a big mountain of complaints forming. The first one, the base is formed by chronic airway inflammation. That leads to bronchial hyperresponsiveness. That is, whenever the patient's lungs are exposed to any allergen, they immediately collapse. This leads to, again, airflow obstruction. So what are the cell-derived mediators which causes the inflammation? The cells which release the mediators are eosinophils, mast cells, and T lymphocytes. The mediators are histamine, leukotrienes, prostaglandins, mast cell tryptase, eosinophilic cationic protein, and cytokines, namely the IL-4 and 5. So what are the symptoms with which the patient presents to us? The major symptoms are wheeze, cough, chest tightness, and shortness of breath. Along with that, there will be nocturnal awakenings in the patient. This is a classical feature of asthma. And there will be recurrent attacks of bronchial obstruction, which is related to the exposure to specific triggers. So what are the special aspects of asthma? Is that allergic or extrinsic asthma, nocturnal asthma, exercise-induced bronchoconstriction, aspirin sensitivity, cough variant asthma, and occupational asthma. So what are the age scenarios which have an increased prevalence of asthma? Asthma will be more prevalent and evident in the age group between 0 to 19, wherein 37% of the patients are affected by bronchial asthma. Among this, also the age ranging between 6 to 14 years, they form the major trunk, wherein 19% of the patients are being affected by bronchial asthma. Later, the disease slowly terminates. What is the burden of asthma on the patient? Asthma is the highest ranking chronic condition causing hospitalization in children. It is the most common chronic illness in childhood. Children with asthma have a 3 times more of school absences when compared with the children who doesn't have asthma. And among the children, 40% of the children with asthma have sleep disturbances, that is about 1 to 2 times per night in a week. And even if the child is not absent from the school, even if he is present in the school, he or she may have reduced school performance because of the sleep lacunae. So how to diagnose asthma? First, we categorize patient based on the classical symptoms of the asthma, namely the wheeze, cough, dyspnea, and chest tightness. There will be presence of nocturnal awakenings, recurrent attacks, which are related to exposure to specific triggers will be present. These specific triggers might be exposure to house dust mite, animal dander, pollens. Whenever there is exposure to these triggers, immediately the lung collapses or the bronchi gets obstructed. The response to asthma-specific therapy, it terminates the asthmatic event. The major in diagnosis of asthma, the most important is the measurement of the lung function. Here we have to utilize one, the spirometry. This is the most important investigatory maneuver wherein we evaluate the patient FEV1, that is forced expiratory volume that is exhaled by the patient in the first second. It is effort independent, that is it doesn't depend on the patient's effort in exhaling. So the forced expiratory volume in the first second is the primary important investigatory maneuver that we evaluate by utilizing spirometry. The second one, it is the time tested and easily available, and the patient can monitor his disease condition at home, that is by utilizing PEFR, peak expiratory flow rate. Peak flow is evaluated. Here, a small handheld plastic machine, that is the peak flow meter. Here, the patient is given the peak flow meter, and the mouthpiece of the peak flow meter is kept in the patient's mouth, then it's kept inside the patient's mouth. Patient is asked to tightly close the mouthpiece with his lips. Then the patient is asked to blow firmly using all his strength into the peak flow meter thrice. This has to be done daily, twice, once in the early morning after waking up, second time in the night before going to bed. Then suppose you say both the spirometry and peak flow meter, the patient lung functions are normal, but based on the patient's symptoms, you sincerely suspect that the patient is having bronchial asthma. Then to confirm that, you have to do the airway hyperresponsiveness to when exposed to different stimuli. The stimuli are by doing the methacholine or histamine challenge test and exercise challenge test. The bronchial provocation, that is why we just discussed this airway hyperresponsiveness, is done by making the patient to inhale a normal suspected amount of the allergen, that is methacholine or histamine. Patient is given some dose of the drug which the patient has to inhale, and we have to wait for some 10 minutes, and then again the process of spirometric analysis is repeated after giving the patient the drug. So if the patient have the tendency of having an asthma, then when the patient exhales the second time, there will be bronchoconstriction. This bronchial constriction is noted by the fall in the FEV1. The fall in the FEV1 would be more than 20%. Remember this, more than 20% fall in the FEV1 is to be noted as positivity for a bronchial provocation test. Here, this is the pathology, pathophysiology, the early and late asthmatic responses. Whenever the patient is given an allergen, within few minutes, around 15 to 20 minutes, there will be bronchial obstruction. Patient will be very much dyspneic, and it slowly terminates. It will not last more than 1 hour. And in the late asthmatic response, this starts around 6 to 8 hours from his initial exposure to the allergen. Then at the maximum, the limit of the FEV1 will be very much low. Then the patient slowly improves. It will take few hours. This is the classical spirometry. This has been given due importance here now. The spirometry is a computerized machine which analyzes the patient's lung functions. Here it notes the FEV1, the forced expiratory volume that is exhaled by the patient the first second, and the FVC, forced vital capacity. In asthmatic, the FEV1 is highly important because FEV1 is the one which doesn't show any effort dependence. It is independent of the patient's effort. So FEV1 is important. Patient is given the machine and the patient has to keep the mouthpiece in the mouth, tightly close it with the lips, and then forcefully exhale out into the spirometer for a minimum duration of 6 seconds. 6 seconds is important, and patient exhales out completely into the machine, then the FEV1 is noted. In an asthmatic, after noting the initial FEV1, the patient is asked to revise this session by, after getting a nebulization of salbutamol or terbutaline, and then after 10 minutes, the patient asked to exhale out, say, like similar to the initial maneuver. In the second time, when the patient repeats the test, there will be increase in the FEV1, classically noted in asthmatic patient. This increase in the FEV1 should be more than 12% predicted. This is important, 12%. Compared to the initial FEV1, the second time when the asthmatic patient repeats the test, there will be improvement in FEV1 by more than 12%. So this shows that the patient's airways are showing the features of bronchial asthma. About the uses of peak flow monitoring daily. Peak flow meter is used to accurately measure the severity of exacerbations. It assesses it in the short term. Peak flow meter is used to evaluate the therapy. It's used to establish the temporal relationship to triggers In the long term, peak flow meter can be used to detect the changes in disease status, to evaluate the treatment, and to provide patients with a written action plan. So normally, in a normal patient, there not be much variation in the peak flow meter reading compared to the mornings and in the nights. But in a patient who is suffering with bronchial asthma, the peak flow meter recording has to be done for 2 consecutive weeks, twice daily, once in the early morning, second one before going to bed in the night. Here, patient keeps the mouthpiece of the peak flow meter in the mouth, tightly closes it, then forcefully exhales into the peak flow meter and thrice. When it's done thrice, the reading is recorded, and the highest reading is recorded once in the early morning and second time in the nights. So the difference between the morning and evening readings will be minimum about more than 20%, more than 20% in a patient who is having bronchial asthma. So these two things, for the FE1 to be nominated that the patient is having bronchial asthma, the difference between pre-bronchodilator and post-bronchodilator FE1 should be more than 12%. Here in FE1, the difference between the early morning and the night PFR should be more than 20%. 20% to nominate the patient to be having bronchial asthma. So the diagnosis here, as per the GINA guidelines, the global initiative against bronchial asthma, these guidelines classifies the disease into 4 different grades. One, mild intermittent. Second, mild persistent. Third, moderate persistent. Fourth, severe persistent. That is, one is intermittent phase, mild. Second one, the second category is the persistent phase, mild, moderate, severe. Here, what are the clinical features that categorize the patient to be having mild intermittent asthma? Here, the patients have asthmatic symptoms which should be less than or equal to 2 episodes per week. And if the patient is having nocturnal symptoms, they should be not more than 2 per month. And there should be brief exacerbations. The patient is asymptomatic and the lung functions between the exacerbation will be normal and the PEF variability will be less than 20%. Both the FE1 and PEF will be more than 80% of predicted value. The second grade is mild persistent. Here, the patient will be having clinical symptoms of asthma of more than 2 episodes per week, but less than daily. That is, it will not be present daily, but it will be ranging between 2 to 6 times per week. In exacerbations can occur which affect the activity. And the nighttime nocturnal symptoms the patient will be having, which will be more than 2 episodes per month. The FE1 and PEF will be more than or equal to 80% of the predicted, but the variability of the PEF, this has to be noted carefully. The variability of the PEF will be ranging between 20 to 30%. In the third category, third grade, the moderate persistent asthma, here the patient will be having symptoms daily The nocturnal symptoms will be more than 1 episode per week, and the exacerbation patient will be having 2 or more exacerbations per week, and this exacerbation affects the activity. The patient uses daily short-acting beta-agonist like salbutamol, terbutaline, and the FE1 and the PEF both ranges between 60 to 80%. That is, it will be less than 80%, but above 60%. The PEF variability will also be more than 30%. Finally, we come to the severe persistent asthma. Here, the patient will be having continuous symptoms and the exacerbations will be frequent. The nocturnal symptoms will also be very frequent, and all this hampers limits the activity of the patient. And if you demarcate the patient based on the spirometric values and PEF, the FE1 and PEF will be less than 60% predicted, and the variability of PEF will be more than 30%. So, if the patient is having acute severe asthma, like we have just discussed, the exacerbation, asthmatic exacerbations, if they are present, how do you detect that? An exacerbation of asthma is not controlled by the standard medication, and patient will be having inability to speak in complete sentences. He'll be very dismayed to complete even a sentence. The respiratory rate will be more than 25 per minute. There will be tachycardia with a heart rate more than 110 beats per minute. There will be pulses paradoxes, but it will not be useful to demarcate pulses paradoxes because 55% of the patients, the pulses paradoxes will be negative. And PFR will be less than 50% of the predicted normal. In patients who are having life-threatening asthma, there will be silent chest, feeble respiratory efforts, and the patient will be cyanosed. There will be exhaustion, confusion, and even coma. Patient will be having bradycardia and hypotension. PFR will be ranging below 30% of the predicted normal. It might be also below 150 liters per minute. About the treatment, in step 1, patient will be receiving low-dose inhaled corticosteroids, namely budesonide or fluticasone. The steroid will be, the latest guidelines say that the steroids are to be given along with long-acting beta-2 agonists like formoterol or salmeterol. The long-acting beta-2 agonists are to be clubbed with the inhaled corticosteroids, which are to be given low dose for intermittent asthma, mild intermittent asthma. And patients who are having increased, who are in mild persistent asthma, they'll be receiving low dose inhaled corticosteroids daily. In step 3, the patient receives the low dose inhaled corticosteroids as well as long acting beta-2 agonists, which are to be taken daily. And in step 4, the dosage of the inhaled corticosteroids have to increase now to medium dose, that is ranging above 400 to 800 micrograms of budesonide. If the budesonide dose is below 400, 200 to 400, it's known as low dose. If its dose of budesonide is ranging between 400 to 800, it is medium dose. And if the dosage of the budesonide is ranging between 800 to 1600, then it is high dose inhaled corticosteroid. And in step 5, the high dose inhaled corticosteroid, which is combined with long-acting beta-agonists like formoterol, is also to be added with some add-on therapy. These add-on drugs might be tiotropium, which is the long-acting beta-2 antagonist, LAMA, or it might be omalizumab. This has to be given by injection, subcutaneously once or twice in a month. This is an anti-immunoglobulin E, anti-immunoglobulin E, IgE. The mepolizumab is anti-interleukin 5, and latest drug is dupilumab. It is anti-IL-4. So this is the GINA guideline picture, which shows there are 5 steps in the treatment. So on the whole, the management of asthma depends on the careful assessment of the patient and monitoring of the patient. The factors which are risking the patient to cause asthma are to be controlled appropriately, and these factors contribute to the asthma severity. Pharmacotherapy has to be clear and approachable, and the patient requires careful, clear education about bronchial asthma. Thank you. An answer to all the questions of dear students when we complete this COPD. So now we have completed what airway disease, bronchial asthma, which is a reversible airway disease. Now we come to the next airway disease, the chronic obstructive pulmonary disease, COPD. Here, in 2020, COPD is regarded as the 3rd most common cause of death and 5th most common cause of disability worldwide. It is characterized by the presence of airflow limitation and airflow obstruction, similar to bronchial asthma. Pathophysiologically, it is divided into emphysema and chronic bronchitis, COPD. This disease is generally progressive, may be accompanied by airway hyperreactivity, and it is partially reversible. This is the major difference between the bronchial asthma and COPD. In COPD, the airways are completely reversible. The FEO1 increases to more than 12%, whereas this reversibility will be absent in the patients who are having COPD. So, going to the definition of COPD, COPD has been described as a disease state characterized by airflow limitation that is not fully reversible. Not fully reversible. The airflow limitation is both progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. So here 2 points. It is a progressive disease, and second one, the airflow limitation that is present in this disease is not fully reversible. About emphysema, it is the abnormal and permanent enlargement of the air spaces which are distal to the terminal bronchioles, along with the distraction of the bronchial valves. About chronic bronchitis, this is also a chronic patient presents with the chronic productive cough for about 3 or more months in 2 consecutive years in a patient in whom all the other causes of chronic cough are excluded. This is the definition of chronic bronchitis. Patient who is having productive cough for 2 consecutive years in each year, 3 or more months. So what are the causes of COPD? Smoking, cigarette smoking. We all know apparently well that cigarette smoking is the most important primary cause of COPD. This is very important. This has to be noted carefully. Generally, clinical significant airway obstruction, it occurs in about 15% of the smokers. And in 80 to 90% of COPD deaths are related to only tobacco smoking. And 1 in 5 deaths, that is 20% of these deaths, are because of cigarette smoking. Cigarette smoking, the nicotine stimulates the sympathetic nervous system, and it results in an increase in the heart rate and increase in the blood pressure, and this leads to peripheral vasoconstriction, and the workload on the heart increases. Cigarette smoking also compounds the problems in a person who is also having coronary artery disease, and there will be decrease in the ciliary activity. There is a possible loss of ciliated cells. All distraction will be present, and the distal air space will be abnormally dilated. Carbon monoxide accumulation happens, and there will be cellular hyperplasia. Secondhand smoke also can cause COPD. It causes a decrease in the pulmonary function, and it increases the risk of getting lung cancer. Even secondhand smoke also is dangerous. And increased mortality also occurs because of the increased prevalence of ischemic heart disease. Infection also can cause COPD. It's a major contributing factor to the aggravation and progression of COPD. For example, if the lungs are infected by tuberculosis and there will be fibrotic changes occurring in the lung parenchyma, that can cause compensatory hyperinflation, and this compensation leads to COPD. Hereditary cause of COPD also exists. This is accounting for about less than 1% of the total COPD patients. Here, the alpha-1 antitrypsin deficiency. This is important. Alpha-1 antitrypsin deficiency. This enzyme usually is produced by the liver, and it is also supplied to the lungs, and in the deficiency of this enzyme, there will be increased proteolytic changes occurring, and there will be lysis of the lung tissues, which are caused by the prevalent neutrophils and macrophages. This diagram shows that when the patient is exposed to tobacco smoke or air pollution, there will be continual bronchial irritation and inflammation. There can be breakdown of elastin in the connective tissues of the lungs. The continual bronchial irritation causes the bronchitis, chronic bronchitis, wherein there will be bronchial edema, hypersecretion of the mucus, and chronic cough. Whereas in emphysema, there will be destruction of the alveolar septa. All this leads to increased airway obstruction, air trapping, dyspnea, and frequent infections. Pathophysiology of emphysema you might also already be familiar with. Here, there will be hyperinflation of the alveoli, there will be destruction of the alveolar valves and alveolar capillary valves, and there will be narrow airways, and there will be loss of the lung elasticity. Pathophysiologically, emphysema is of two different types. One, the most common, is the centrilobular or centriacenar, wherein the central part of the lung is affected. The second category is the panlobular, wherein or panacenar, wherein the entire lobule is destroyed. This is seen in the genetic disorder that we just discussed, the alpha-1 antitrypsin deficiency. About dyspnea, it progresses in severity. Patient will first complain of dyspnea on exertion, and it progresses to even interfering with normal daily activities, and it will also be present when the patient is even resting. Clinical manifestation, patient will have a minimal cough with no to small amounts of sputum, but there will be over-distension alveoli, which causes the diaphragm to flatten and the epidiameter to enlarge. So there will be enlargement in the epidiameter of the chest, and there will be flattening of the diaphragm. Patient becomes a chest breather. He relies on the accidentals of respiration to inhale and exhale. To do his respiratory activity, the patient has to depend on the accidentals of respiration. He becomes a chest breather. The ribs become fixed in inspiratory position. Even though the patient takes adequate diet, he will be usually underweight because of the excessive energy that he has to use in doing the respiratory activity. The pathophysiology of chronic bronchitis, there will be hyperplasia in mucus secreting glands of trachea and bronchi. There will be increase in the goblet cell. There will be disappearance of the cilia, chronic inflammatory changes and narrowing of the small airways occur, and the altered fraction of the alveolar macrophages leads to increased prevalence of infections. there will be greater resistance to airflow, and this increases the work of breathing. The increased calories have to be utilized by the patient for this respiratory activity. There will be hypoxemia and hypercapnia, that is, the oxygen levels in the blood will be less, and CO2 level, the contraction levels in the blood will be high. Hypercapnia develop most frequently in the patient who are suffering with chronic bronchitis when compared with the patient suffering with emphysema. Cough is often ineffective to remove the secretions because patients cannot breathe deep enough, and the bronchospasm frequently develops, which is more common in the patient with the patient having a history of smoking, and if the patient is an asthmatic even. The earliest symptoms are frequent productive cough during winters and frequent respiratory infections. There will be bronchospasm at the end of the paroxysms of coughing. Cough, dyspnea, exhaustion, and history of smoking, they go in line with the diagnosis of chronic bronchitis. Patient's weight is normal, and or because of the accumulation of, he might be even heavy set. The patient's skin appearance will be ruddy or bluish red appearance. This is due to the presence of polycythemia. This polycythemia is due to the chronic presence of hypoxemia. The oxygen levels will be low. To counter that, the blood accumulates more, generates more amount of hemoglobin. This increased hemoglobin is seen in the patients who are suffering with chronic bronchitis. Polycythemia, cyanosis also will be present in them. With hypoxemia and hypercapnia, the low oxygen and high carbon dioxide, it results in the hyperventilation and an increase in airway resistance, which leads to the problems with the alveolar gas exchange. The chest X-rays early in the disease may not show any abnormalities, so we have to rely on the history and physical examination. The pulmonary function test also shows a reduction in the ratio between FE1 and FVC, forced expiratory volume in the first second, which is by the forced vital capacity, and an increase in residual volume and total lung capacity will also be present. So not only the ratio will be decreased, and there should be an increase in the functional residual capacity, residual volume, and total lung capacity. On X-ray, to identify the patient having COPD, there should be bilateral hyperinflation, a heart which is narrowed down, tubular heart, and a diaphragm which are flattened. That leads to hyperinflated chest. To categorize the COPD, the GOLD guideline, the Global Initiative for Obstructive Lung Disease guidelines, they grade the patients into 4 grades, grade 1, 2, 3, 4. Grade 1 is mild COPD with a FE1 by FVC ratio less than 70%, and the FE1, the forced expiratory volume that is exhaled in the first second should be more than 80% predicted. This is mild, and moderate or grade 2 COPD, or the ratio again is less than 70. but the FA1 should be ranging between 50 to 80% of the predicted. In grade 3 or severe COPD, again the ratio is ranging less than 70% and the FA1 is ranging between 30 to 50% predicted. Here it has been noted that whenever the FA1 cat goes below 50%, there are many chances that the patient lands up in type 2 respiratory failure. Grade 4 are very severe COPD. Here again, the ratio is less than 70% and the FA1 will be again less than 30%. Collaborative care, smoking cessation is the most chief important factor. The bronchodilators are to be applied as maintenance therapy. The beta-2 agonists, the salbutamol, terbutaline, also the anticholinergics like ipratropium, tiotropium, all these are used for medication. In the medication, the oxygen therapy has a pivotal importance. And the oxygen therapy raises the PO2, partial pressure of oxygen in the inspired air, and it treats the hypoxemia, which is most commonly prevalent in these diseases. The oxygen has to be titrated carefully, and the lowest effective dose has to be applied to the patient. Chronic oxygen therapy at home, it improves the prognosis, it also improves the neuropsychological function, there will be increased exercise tolerance, there will be a decrease in the hematocrit, the PC, the packet cell volume will be less, and there will be the oxygen also helps to reduce the pulmonary arterial pressure. The respiratory physiotherapy is of importance in these patients. The breathing retraining using the pulsatile breathing and diaphragmatic breathing. These two methods are important. Huff coughing, chest physiotherapy, it is used to bring the secretions into the larger and the more central airway so that they can be expelled out. These chest physiotherapy maneuvers are postural drainage, percussion, and vibration. We have to encourage the patient to remain as active as possible. Surgical therapies like lung volume reduction surgery and lung transplantation are available for the treatment. The nutritional therapy, here it has been noted that full stomach press on the diaphragm and it causes high increased dyspnea and increased discomfort. So the difficulty, there will be difficulty complying with the patient while eating and breathing at the same time because this leads to inadequate amounts of food being eaten. Nutrition therapy, avoid gas forming foods, high calorie, high protein diet should be are recommended and supplements are to be given and avoid high carbohydrate diet because this prevents the increase in CO2 load. Health promotion is important. Stop smoking. This is the main important attitude that has to be remembered by the patient. Stop smoking. Avoid or control exposure to the occupational and environmental pollutants and irritants. Early detection of airway diseases, small airway diseases also helps, and the early diagnosis of respiratory tract infections is of primordial importance in these patients. Thank you. If, my dear students, if any one of you want to clarify, you post me the questions. Girish Salamane. You can post all your queries now. I'm waiting for your questions. క్లాస్ అయిపోయింది వాళ్ళ క్వశ్చన్స్ అది చూడాలంటే అలాగే చెప్తాను చాలా ఉన్నాను మీకు తెలుసా గిరీష్ రావణ mainstay of treatment for emphysema. The mainstay is bronchodilator. It all depends on the grade in which the patient is suffering from. We have charted down 4 different grades of COPD based on the gold guidelines. Whenever the patient is in grade 3 and 4, there has to be a steroid that has to be added. In grade 1 and 2 COPD, the bronchodilators, namely the beta-2 agonists as well as anticholinergics, the ipratropium and tiotropium has the most important part. But in grade 3, along with the bronchodilator steroid, as well as in grade 4, the oxygen has to be added. Steroid, oxygen, and the anti-allergic injections have to be used. Right. Any question? Is read index commonly taken for chronic bronchitis? Read index doesn't comply with the dyspnea that is seen in chronic bronchitis. Read index doesn't comply with that. Yes. Any other question? Next question. If there are no more questions, the next teacher will be teaching you. Bye.
Broadcast.
No, sir.